Good afternoon, everybody, and welcome to today's webinar session. Today we will be doing Bridging the Gap, Treating Eating Disorders in Autistic Individuals, Lived Experience, Family and Professional Perspectives. And with that, I will hand you straight over to Emily, Deirdre and Zuzanna.
Thank you very much. Good afternoon, everybody. We are delighted to be here today to share experiences of autism and eating disorders from a personal, family and professional perspective. So just in terms of who we are, I'm Deirdre Reddan. I'm the co-founder of Supported Families with Zuzanna. We educate and empower families, professionals and individuals with lived experience of eating disorders. We work fully online. I myself am a parent who supported my own child through an eating disorder, which led me to leave my career in banking and retrain as a coach and in eating disorders. Zuzanna and I co-founded Supported Families a number of years ago because we passionately believe in the often untapped superpower of families to support recovery. And we also run events for professionals.
My name is Zuzanna Gajowiec, and I'm a clinical psychologist and a family therapist. I'm also a certified eating disorder specialist and consultant. So I have an over a decade experience in the field of eating disorders, working on all levels of care. And I'm really dedicated to supporting individuals and families in their journey towards recovery and healing. And I'm also an International Association of Eating Disorder Professionals chapter chair of Ireland, which I really embrace and really love that new role.
I'm Emily, so I'm a expert by experience. So I've got lived experience of anorexia with autism, and I work for the State of Guernsey Autism and Eating Disorder Service, and I also work for Peace Pathway, and I'm currently doing my level 3 counselling training and doing lots of national work with autism and eating disorders across many services.
So in terms of what we're just going to talk in a second about what we will cover today. But first of all, we would like to get a sense of who is in the room. So I think Aish is going to put up a poll that we would appreciate if you could respond to. It's totally anonymous, but it's just to get a flavour of who's here with us today so that we can kind of tailor our content a little bit. So we'll just give you a quick second. And then if you just want to share.
It says that host and panelist cannot vote.
Yes, we can't, but everybody else can, I think. So Aish, if you'd like to share the results maybe, and we can move on.
Absolutely will. We've still got some answers coming in. We've got 315 out of 370.
Okay.
They're just still coming through for a second.
Right.
That seems to have slowed down quite a lot. So in the interest of time, I will end that poll there and share the results so that you can see them there.
Lovely. Okay, so we have a lot of professionals in the room and some individuals with lived experience and caregivers. So you're all extremely welcome. It's nice to have the mix of everybody here. So today we're going to try and bring a broader perspective to the topic of autism and eating disorders. Worth pointing out that today we're focusing specifically on autism. However, there are links with eating disorders and other neurodiversities too, and I suppose they're topics perhaps for another day. Zuzanna and I are really privileged to have Emily with us today, sharing her personal experiences and recommendations to professionals based on what she experienced during her own illness around how treatment can be adapted and improved. I'll be bringing the family perspective and Zuzanna will be speaking from a professional perspective. So we will be looking initially at autism and eating disorders individually. High-level overview only because they are both complex clinical areas requiring specialist care. We will be looking at them together and how they intertwine and overlap. We will also be looking at how treatment can be harmful and how it can be helpful. I suppose we as professionals and caregivers do need unique skills and sensitivities to care for this population properly. We've a lot to get through, but we plan to leave time at the end for Q&A. So if you'd like to pop any questions into the Q&A function, We'll answer as we go along, and then we'll leave time at the end. And if we do happen to run over time, because we've a lot to get through, this session is being recorded, so we'll be available to watch back. So in terms of autism, I suppose it's the autism spectrum is nicely depicted here on the slide. It is not linear, and it's very much about differences in experiencing the world in terms of the sensory world, in terms of communication, thinking, socializing, and how trauma is being experienced. So very much differences in communication and interaction from a social perspective. Often for somebody who is autistic, there can be restricted, repetitive patterns of behavior, interests, or activities. So restricted or fixated interests, perhaps, often hyperactivity or sensitivity to sensory input, repetitive motor movements, focus on sameness, huge reliance on routine. So, and often, and most importantly, it's fluid. As I said, it's not linear, it changes every day. So every day can be different for the person who is autistic. So there can be anxiety and communication overload maybe on one day and less so than the next. Important also to stress that the approach in recent years, thankfully, has become a lot more person-centered, and the language around how we describe autism has also changed. So autism is very much separate from what gives that person value or worth. So it is really important that we ask people how they would like to be addressed or described, because some people will say, I am autistic, and other people would prefer the use of the word, I have autism. And there's also a lot more focus now on strengths rather than deficits, which again is to be welcomed. Often the symptoms can be present early on in the development of a person, but sometimes it's only when the social demands are greater than the capacities of the person that the symptoms become more apparent. And we will often people can mask, and we will be looking at that shortly. Evidence-based research is really highlighting delayed diagnosis, particularly for females. So here in Ireland, there's very limited access to specialists and care, and we understand that the UK is no different. So where there is delayed diagnosis, it's very important that there be developmental and observational assessment, particularly important for adults because the parents may not remember what early childhood was like. And often diagnostic overshadowing. So for example, and this is something we will be looking at today, obviously, but if somebody's diagnosed with an eating disorder, the autistic traits can get overshadowed by this. So it's something we will talk about later. Females are more likely to experience internalizing rather than externalizing difficulties than males. And often people are referred for assessment if there are external difficulties. So for females, and Emily will bring us through her own story shortly, it's often under-recognized unless there are coexisting behavioral, emotional, or cognitive difficulties. Also, the standard diagnostic tools are developed based on males. So females do tend to show more subtle communication difficulties. Symptoms are less pronounced, as I've said, and often they will have gender-typical hobbies such as makeup, fashion. So again, not as apparent perhaps. They also camouflage and mask more. And often the autism gets diagnosed after the eating disorder. And Emily will share her personal experiences now in a few minutes.
So eating is also a spectrum, and I will try as quickly as possible move us through the whole range of different things we can encounter. But let's start maybe with the so-called healthy or so-called normal eating. Both of those terms are a little bit problematic, so I will maybe sometimes use the word optimal eating. And as you can notice here on the slide, it is shown through the very kind of neuronormative lens. So a lot of the things listed here, like exercising for health and fun, might not be accessible for someone who's autistic. Also, acceptance of the body as it is might be difficult because sometimes just existing in the body is overwhelming because of the sensory input. And also definitely eating from all food groups might be not eating from from all the food groups might actually be a normal behavior in terms of people on the autistic spectrum. So we have to be mindful that we actually come often with the bias of what a normal eating is, and we have to definitely be more flexible with this population. Another thing about the so-called healthy or normal eating is that we have a lot of ideas that, for example, healthy eating is eating when we are full and stopping when we are hungry and stopping when we are full. Again, normal eating is also occasionally overeating, occasionally undereating, even eating emotionally or eating for social reasons. Eating is such a complex, have so many functions in our lives. So this is all normal. I think it becomes more, so not to confuse it becomes more disordered when we rely on it, or it becomes our primary or maybe the only coping mechanism or the only way that we cope with certain things. And in terms of the disordered eating spectrum, it is much less intense and much less severe than the eating disorder spectrum. But again, some of those behaviors can be quite challenging for the person or might be quite distressing. So it's just a matter of intensity and how it impacts the person's everyday functioning. But what's also important to note is that people who are in the disordered eating spectrum deserve interventions, deserve help, which often doesn't happen. And again, we have so much research about early intervention being the key, that this is very sad. But I think part of the problem is that we live in such a biased culture. We have a lot of kind of dieting views that became normalized. So it is actually hard nowadays to discern the disordered behavior from normal behavior, because they just became so normalized, so popular. And then, of course, on the eating disorder side of the spectrum, this is quite severe behaviors, behaviors that really severely impact the person's health, ability to socialize, and their functioning. So again, the main thing I would like us to kind of be sensitive to is that we really need to look at the ideas of healthy and unhealthy eating from the perspective of someone who is autistic. And I think there's always danger, and I will speak about this a bit later as well, that we might treat the things that don't need to be treated, or nearly force people to be more neurotypical than they are. So we just have to be very sensitive to that. So I want to talk about a few statistics about autism and anorexia. So some research estimates that as much as 23% of people with eating disorders are also autistic. Again, today we're speaking mostly about anorexia and autism. So 1 in 5 women with anorexia also has autism, and you have some of those research kind of cited here. And then 16.3, there's a 16.3 prevalence of autism in anorexia nervosa, so quite high. And autism often precedes the eating disorder diagnosis, as Deirdre said, not always, because sometimes it's very well masked. So so that sometimes it's a problem. And then what's really, really important for us professionals to know is that those with autism might experience more severe symptoms of anorexia, and sometimes they have poorer outcomes. Again, the poorer outcomes are often not connected to the autism or the eating disorder, but how bad we are at treating them at the moment, and we'll speak about this later. Yeah, so there's a very clear overlap. Again, this is very clear in research that autism spectrum and anorexia share a lot of the features. So there are biological components that are similar, genetic, and in terms of the structure of the brain. Neurocognitive overlaps, particularly in the rigid thinking style, how people are so focused on detail, how people have difficulty switching between tasks or need more time to switch from one task to another. Many people crave routines, rules, and rituals. And in terms of the social and emotional overlaps, the main one is high levels of anxiety, or the most visible. Some people will struggle making friends and maintaining relationships in both in anorexia and autism. And people also have difficulty regulating emotions. I think in terms of eating disorders, the difficulty regulating emotions increases as the severity of the eating disorder increases as well.
So I want to talk a little bit about masking with autism and anorexia from my lived experience. So I always ask this open question of what do you see when you look at me? So I guess this comes from a mask that I wore in my experience of I'm fine. And many professionals, many sort of friends, families and colleagues didn't really recognise that my eating disorder at first. They didn't recognise that I had autism. So I would just say I'm fine to hide the illness and hide the autism. But I guess over time in my journey, in the last sort of 10 years, there was kind of things that came to light that realised I wasn't fine. So the pre-assumptions that people made, but actually once people started to ask me sort of open questions, you know, of just what I needed, how they could help me, and just by listening and sitting with me, that was really, really important. And to not make those assumptions, because, you know, eating disorders, particularly anorexia, can have any look, and the same with autism, as we've just shared, that it is a, you know, a spectrum, and that actually there's so many ways that people present with autism and eating disorders. So it's just keeping that open-minded approach and asking those really empowering open questions to make those connections and hopefully start those conversations, because I'm still Emily, I'm still an individual, and yes, I have autism and experience of anorexia, but that doesn't define who I am. So some of my story, for me, so I was diagnosed with anorexia at the age of 12, which was a very long time ago now, after struggling sort of silently for 3 years prior to my diagnosis. And within that, I was referred to the CAMHS mental health and eating disorder team. And I went through a period of lots of outpatient treatment, followed by 2 inpatient admissions into CAMHS treatment services across the country. And for me, at that stage, they said that I possibly had autism, but they just did a brief assessment within like paediatrics and children's services, which confirmed Asperger's at that point, which is a type of autism. Nothing really happened, unfortunately, in my treatment. I was treated as an inpatient for nearly a year, and I just then had adapted sort of therapy for my eating disorder, but it didn't really work, unfortunately. And then when I left CAMHS, I was then transferred to adult services, and unfortunately spent 2.5 years in inpatient and day patient treatment. Again, not any adaptations. I was in a noisy, sensory, loud, distressing environment. You know, meal times were really overwhelming. No one really could communicate with me. I couldn't communicate with other people. And it was only after this 2.5 year inpatient and day patient admission, I was reassessed for autism and had a confirmed diagnosis in October 2017. And I was then referred to a autism and eating disorder specialist service that I now work for as an expert by experience in my area. And that, I guess, was my game changer, if that's the right word. And that really sort of transformed my journey into outpatient treatment, and a lot of the environment was adapted. So, you know, for me, being in loud, sensory, overloaded environments, we adapted it with what we called blank canvas, of making sure the environment was safe. You know, the treatment was adapted, and I just had professionals that really cared about me. And that really got me to a place that I'm grateful to be at now, that I am in that recovery place. I know what causes my eating disorder, the triggers. And the biggest thing about my autism is that I know how to engage with those people, and people know how to understand me and understand myself and others. And I think that's been really empowering, and it's brought out who I am now. And compared to where I was even this time 10 years ago, it's embracing that journey and motivating myself and just growing. And the work that I now do in lived experience is changing that for services. So hopefully making a difference and bringing change. So being autistic, and this is something that my family picked up on, and I guess from a very young age, having other disabilities as well as autism, I'm a very visual interpreter of my struggles and my experiences. So my experience with autism and anorexia, I refer to it as the washing machine in my brain. So basically that's for me is my thoughts, feelings, the behaviours that I was showing was all churning around inside my head. it was really, really overwhelming, really jumbled up, really messy, and I couldn't really unpick it very well. And that for me would cause what I experience as meltdowns, shutdown, and everything just kind of disconnecting for me. So I really struggled to then engage in the right help and support and the right treatment. So for me, in my therapy, I had to learn to break everything down and kind of almost like taking the clothes out the washing machine, dealing with it a bit at a time. Once I dealt with that, I could fold that away, put it away, and come back to it if I needed to. And, you know, for me, you probably all know The Greatest Showman. You know, we all say that being yourself is the greatest thing, you know, because by being different, we do succeed, and we are who we are. And yes, we have these labels, but we're still an individual and we're still amazing in our own special ways. So for me, having to find those strengths and those abilities and those skills that I still had underneath the anorexia and the autism was really important, and embracing those in all areas of my life. And that's been a big part of my recovery and grown me to where I am today. So treatment for an autistic person with an eating disorder, what doesn't work? So as I briefly mentioned, was the clinical environments and the sensory overload. So, you know, unfortunately, we don't have control of all these environments that eating disorder treatment takes place in. You know, my ideal world, we could knock down a building and rebuild it to make it adaptable, but that's not going to happen. So, but actually the simple things, so we talk about blank canvas, we talk about just having, you know, plain environments where, you know, because actually the clinical environments for me, they were very bright, as hospitals have to be. They're very loud, very noisy, and it was just really, really sensory overload. And I couldn't really engage. I was just so shut down by the noise that I was completely disconnected from the support and treatment. And I've had experience of treatment of mantra therapy, SSCM, CBT, DBT, art and trauma therapy, and EMDR therapy in all my day patient and inpatient and outpatient treatment and CAT therapy. But a lot of these treatments, until I got my confirmed autism diagnosis, weren't adapted. So they were very clinical, very rigid. And I had to just sit and engage in group therapy, individual therapy, and family therapy. And I really struggled. And unfortunately, professionals used words such as disengaging, not willing to cooperate with treatment, and not willing to get better. So that was kind of a lot of labels put onto me, and that, you know, they were threatening me with discharge and telling me that I didn't want to get better, that I was wasting their time, whereas actually I wanted treatment, I wanted help, but I didn't have the treatment adapted to understand it. So I just couldn't engage with it. And it was only when, you know, that change then happened, this took place. And for me as well, you know, things happen in life, you know, treatment changes happen, sometimes predictably, unpredictably, but often things would change very quickly with my treatment, and they wouldn't tell me until that day when I'd arrive and say, oh, sorry, this is happening today, or this person isn't in. And, you know, that was really, really overwhelming for me. So I would have to sometimes see like a step-in person coming to help, or, you know, I'd have to do something different with my dietitian that day, or see a different eating disorder consultant or a different therapist. And then again, that would cause me to shut down because I hadn't been able to build that trusting or understanding relationship. So that kind of then brought this, as we say, a cycle of trauma. The more I shut down, the more I disengaged because of the trauma of the feelings and having to not be able to express myself. I guess I internalized that anger and disconnection, partly with my autism, because I didn't know how to get it out, but also with the eating disorder as almost like a punishment and a way to just not feel present in any of it. So that was a really vicious cycle that I went through for numerous years. And I think that was quite a scary cycle that I had to learn to eventually break.
So I really love this term, help that helps versus help that harms, that I've learned from my mentor, Dr. Karen Samuels. And I think it fits very well here that in my experience, all eating disorder professionals are very driven, very empathetic, eager to learn people, but we still yet cause a lot of harm and sometimes don't adapt the environment enough, like Emily just said. So I think it's all we can get more training. We've trained in all of them. IADEP, the International Association of Eating Disorder Professionals, Peace Pathway, NED, they really provide amazing treatment. Training, sorry. I might have got lost for a second. Sorry for my internet, there's nothing I can do about this. I think something that could be easily fixed is actually early screening. So what Emily said, it makes a huge difference for the person when they actually viewed as a person with autism, and they don't have to fight for the accommodations, hopefully, or there's more room for accommodation. So I think just adapting by using a very basic screening tool. Again, screening is not a full assessment. Of course, we can still refer people for full assessment, but it should be enough to inform us that we need to do better, and we need to really make sure that the person's needs are taken into consideration. And also, I think it's really important that we respect the self-diagnosis, because at the moment there are so long waiting lists. Also, access to assessment is quite limited. So when people self-identify, we just really need to take that on board. So I just want to give another example of the help that helps. So this would be someone that needs to be admitted to a ward or to a residential treatment center. Again, there's not necessarily a specific need for the sudden admission, but the admission is done in a very sudden way. They're seen by multiple professionals over a short period of time. So again, they put in this very overwhelming situation that someone's sitting in front of them and ask questions, and they put on the spot and they have to answer, which can be very distressing. Family is not welcome to the ward, or they can't support or maybe help the person settle. There's no gentle introduction to the environment. It's kind of dropped into this environment. Noise on the ward is overwhelming, and particularly the situation around food is very overwhelming. So there's a loud TV or radio on during meal times. The food itself is overwhelming, the sensory aspect of it, the unpredictability, maybe being asked to eat things that are completely new to the person that they never ever touched in their life. They are asked to sit at a different seat each time. There's, again, no predictability. They often kind of wander around, not knowing where to sit and if they're going to feel comfortable. There's no notice given to changes. This is what Emily just mentioned, how distressing that can be when things just change all the time, or things change and there's no time given to adapt to that. And then I think in terms of how the person actually would benefit, or would the person benefit from talk therapy or different therapeutic intervention, that can be problematic as well. So a lot of the talk therapy can be confusing or can be overwhelming, could put the person in a very uncomfortable situation that they actually are not able to open up or not able to talk. And yeah, we have to take all those things into consideration. So when the help is actually harmful, and in this particular example that I'm giving you, it resulted in a shutdown. The person was not able to cope emotionally with what was happening around them. So in the shutdown, of course, this affects our ability to eat. So the person was not able to eat at all. Their eating deteriorated, and the blood sugar dropped to the point that they had to be hospitalized. So I think what's really important to note from the professional perspective, sometimes we think, oh, about the accommodations, this is a lot of work for us, but actually it will make our life easier, and we will be much more successful as professionals when we provide those accommodations. So it's not only, of course, to benefit the person, but we also like to do our job well and succeed. So this is really important.
And then for parents and carers, so the caregiver burden is higher for eating disorder caregivers, in other words, caregivers who are supporting somebody with an eating disorder, than for other caregivers supporting somebody with a mental illness. So the research suggests that the burden is greater on caregivers supporting somebody with an eating disorder. But for caregivers who are supporting somebody with an eating disorder who is also autistic, again, the evidence suggests that those caregivers experience increased levels of stress and anxiety. So it's greater than for other caregivers. So as we said at the start, they are both complex areas. So managing an eating disorder and a person who is, or supporting a person who is autistic, they're very high intensity. It is very hard. And why else is there an increased burden? Often for parents and caregivers and family members and partners, they have been to multiple professionals who often don't specialize in eating disorders and autism, which makes them more guarded. They feel unheard because clinicians often focus on the eating disorder or the autism, not both. There aren't very many integrated pathways at all, and I know there have been some questions in the Q&A about that. Sometimes the treatment teams dismiss the possible autism diagnosis, saying it's not relevant. It 100% is. So I think for any professionals who are here today, I hope we will take that away. As Zuzanna mentioned, it's so important that we do, as professionals, have training in this area. So often caregivers and their loved ones often feel that they can't find the right fit. The caregivers have a tendency, as I've said, to be more at capacity, and they often carry an enormous amount of guilt and blame. So wondering, was there anything they did wrong in terms of their parenting style and pregnancy? Or, you know, blame around, oh, you should have had your child assessed sooner. So they deal with a lot. They feel like hopeless cases because the providers often will dismiss the autism. So clinicians will say, oh no, this is all eating disorder related. And once the eating disorder is treated and once your loved one recovers from the eating disorder, it'll all be fine. It'll get better. And also there can be grief. So diagnosis can be a relief. An autism diagnosis can be a relief, but it can also bring a sense of grief with it too. And it's harder for caregivers to get the necessary social support that they need. So you have all of this going on. You have it compounded by the impact of the eating disorder. So in lots of ways, autism makes anorexia feel like it's anorexia on steroids. So it can just heighten the impact and the complexity. And it can also impact partner relationships. So giving rise to higher stress levels, negative partner interactions, finding it really hard to kind of identify good things about the person, positive contributions of them, and can lead to ongoing family struggles. But it can also positively impact partner and family relationships because everybody has to pull together. I think it's fair to say that the lack of support for caregivers who are supporting somebody who's autistic and also struggling with an eating disorder is also very challenging. Or sorry, there's a lack of support, full stop.
So some of the accommodations that we think about, so in terms of, I guess, the treatment accommodations particularly. So when I was in generalised eating disorder services and inpatient and day patient treatment, when I got moved to my autism and eating disorder service, I was under the outpatient service. So perspective on effective accommodations for me was that I got to meet my team before I was transferred. So I had pictures of all the professionals, who they were, what their roles were, how they were there to support me. So it's like a little booklet, and I could then write questions about those roles and what they did, and they would then give me answers. And for me as well, it's just a question I've also answered to somebody, is adapting the treatments, which I'll share a bit more about as well. But having the creative outlet, you know, having that opportunity, it's understanding who that individual is with their autism diagnosis, that they all have amazing talents. And for me, I'm a creative person. So having art therapy, drawing, the use of sensory objects. So I have ear defenders and ear plugs, I like to call them. And that was like really like noise cancelling headphones as well. That was really important. So I could still go into environments, still be engaged, still be prepared to be engaged with my treatment, but block out the external noise. For me, it was also about having pens and paper in the therapy and treatment rooms. So I could draw anything that I was experiencing. I could draw what my eating disorder was looking like, behaviours, what I was feeling, how it represented, because often I couldn't visualize verbally what I was saying. So drawing it out was really important. And the use of music and art therapy, again, was really important. Drawing out my experiences and me playing the piano and guitar and singing, that was another really, really important thing. So having those therapies in there was crucial. And even in the right environment, sometimes I would go into my building and it would just still be too overwhelming. So we would have outdoor spaces. So if I was well enough or if the weather was better, I could take my treatment outside. And again, it's about, you know, some of the other things is the routine. You know, when I was in my treatment, I had routine A and routine B, we called it. So we'd have routine A for like specific weeks of what it would work. So when I'd see the dietitian, when I'd see my eating disorder consultant, when I'd see the nurse, when I'd see the psychologist, when I'd see the OTs or support workers. And then we would then also have a plan B and C, so that if any of them are off sick or on leave or not in for that day for whatever reason, it would tell me who the backup contact would then be in those situations. And also as well, I'd have treatment adaptations. So for me, I knew what my recovery needed to be, what it looked like, how it would feel. But often with life, unpredictable things happen to all of us. You know, things happen, and that's part of the journey of life. So for me, I had to have a trigger awareness plan. I had to have like a safety plan. And also having plans of, you know, if I'm not coping, what skills do I use? What resources do I use? And who do I reach out for support? And also with communication across the teams. We're very fortunate in my area that we have computerized shared systems. I'm not technical in any way, shape or form, but having like shared systems within your teams was really important, so that actually if you do have a meeting, like for me having a review with a dietitian, for example, or a review with a psychologist, actually they would then communicate that into the internal systems to the rest of our team in the service, so that they could see those updates before they would then meet with me and talk about it. And as I said, creativity across the therapies, so whether that's art, music, writing, we use communication boards, worry worms, worry jars, traffic lights for distress systems, and that actually having the right environment to do that in. So sometimes I'd sit in the garden area for my therapy if it was quiet. I'd sit in one of our therapy rooms, or I'd go and actually sit in, we managed to make one of our blank rooms like a bit of a sensory room, so having like just sensory lights, calming sounds, and that was again all these different options. And I'd have that question asked to me when I go into that environment today: what room do I need to be in, and what do I need in that room? And that actually I'm still a human being. Yes, I've got these 2 diagnoses, but I'm not that on a piece of paper. I'm an individual, and having to embrace that person for me is really important, and treating me as that individual and not what you see on a piece of paper. So that is a really big thing to hold on to. So in terms of the environment and the treatment, it completely depends on the environment that that individual is being treated in. Obviously, unfortunately, my inpatient and my day patient, none of that was adapted because my autism wasn't picked up at that point. So it was very clinical, very loud, very noisy, and, you know, it was full of alarms, you know, other very poorly people, and, you know, the treatments are very rigid. And obviously, because they had so many people in that generalized service, I didn't really have my needs met for therapy or treatment or support. But when I moved to the autism and eating disorder service that I now work for, when the environment was adapted to I call it my blank canvas. So it's white walls, and I go in there with an open-minded approach of, you know, what do I need to engage in this environment? What would make you feel present? What would make you feel connected? And what will make you feel grounded, safe and supported? And we also use a technique which I helped develop with some clinicians called the 5-4-3-2-1 technique, which is the grounding trauma technique. But actually people for autism and eating disorders, it really works. So the 5 things that you can see, the 4 things that you can hear, the 3 things that you can touch, the 2 things that you can smell, and then taking a deep breath. Because by bringing that into the environment, that can be really calming for an individual. Because if you go into rooms where there's lots of pictures on walls, lots of things you're very distracted by, if it's really noisy, you know, sometimes there's really horrible smells. You know, through COVID, we obviously had to have all the alcohol gels and all these awful things in these rooms that made it smell pretty awful, but it had to be done clinically. But actually, once you bring in those safe smells and what that individual likes, that's really important. And bringing in those creative therapies, those talking therapies and those adaptive therapies, and bringing them together. So we have individuals like me who write songs as part of their therapies with one of our eating disorder support workers. I've experienced that. I have dog therapy. I have creative art therapies, writing therapies. And actually, you know, by writing down and visualizing. So obviously the main treatment for eating disorders is CBTE, mantra and SSCM. actually drawing out those therapies was really, really important. So I could, still have that kind of therapy, but understand it visually, what it meant, what it looked like. And I would then visually express my process of that journey of what I was going through and work through that. And that got me through that process. So that was some really important things to take on board. So in terms of communication, this is a really massive thing. And this is something that I've recently done in some of my lived experience work with my job at the Peace Pathway. So communication with autism and eating disorders is so, so important, because for me personally, in my experience, I had wonderful professionals, but there was often a language barrier or cultural difference, which I loved. But again, I was not always understood. So, they couldn't understand me, I couldn't understand what they were saying, and I become really, really overwhelmed by the autism and actually shut down and disengage. So actually, we can send the link out after, but the Peace Pathway have an amazing communication passport. And you can create your own. We've created some of our own with some of our service users because of part of my lived experience role, but actually the importance of communication. So we have the sunflower lanyards as well as these cards, and we ask simple questions of what do you need to communicate? Do you need to write? Do you need to draw? Or do you need to verbalize? How do we need to communicate back with you? What would help your communication? What makes your communication worse? What makes your communication better? And if you are in crisis or struggling, how do you communicate? And we also have communication boards. So we would have boards in every single one of our therapy rooms with different pictures, with different words and different things that related to treatment, so that individuals could actually go and pick up those pins with those pictures and put them onto their communication board when they came into treatment of what they needed to communicate. So some of those adaptations can be really, really important, because it's not much adaptation, but actually it's life-changing for someone with autism, because they're then putting what they need, in front of somebody to communicate. And, we have people that are non-verbal with autism and eating disorders. So we've learned sign language, we've learned to use technologies, again, not my greatest strength, but to engage with individuals. So that's some of the key things to think about. So becoming Emily away from autism and anorexia. So for me, I'm after all these years. So, I struggled with anorexia from 2005 before I was diagnosed in 2008. So 19 years down the line. It's quite scary to say that. For me, I'm in a place now where I fortunately do not engage in eating disorder behaviors anymore. I'm aware of my triggers that could potentially become, for me, going back to the eating disorder to cope, because a lot of my eating disorder experience was from life traumas, from having a physical disability, from my autism, from being bullied, from, lots of other life traumas, and not feeling in control of my mind, body, or my life. So for me, actually, I've had to learn, I have trigger plans, I have safety plans, communication plans, and I've become my own best friend. And that's a really big part of my journey. And I've had to learn to accept myself for who I am, despite my diagnosis, that actually I'm still an individual, I can achieve in my own way. And that, we have a saying that by being different, we succeed together. And that's been something I've taken on board, and I've become my own best friend. And I can't really imagine myself saying that sort of 10 years down the line. And for me now, life is so different. I'm training to become a counsellor and doing all this wonderful work and lived experience. And I just feel connected to myself again. And because professionals in our autism and eating disorders know how to connect and support me, I'm very fortunate that I'm in a system in my service where that if some of my triggers do come up, or if I'm struggling with certain areas of my life again, I can just check in with these professionals, have some top-up support sessions. And that's really, really crucial, because that keeps me going on the right path. They're aware of my triggers, they're aware of what might cause me to relapse, and they intervene in those instances, and that keeps me on that journey. And that's helped me to grow every day. And that's something that I now embrace in my recovery.
Cool. Maybe giving another example, this time of the help that helps. Again, a lot of those things Emily just mentioned earlier. Just want to give you another example. So we need to put in place practical sensory communication adaptations, as Emily said. So let's imagine another person, and they also need admission to the ward or admission to residential treatment center. But this time their admission wasn't rushed. They actually had the time. It was planned. It was very well discussed. They had time to ask questions. All the questions were answered before they even made the decision. The assessment took as long as it needed to take for the person to not be overwhelmed, for the person to take breaks, maybe for the family members to be there with them, support them if there was a need. The written information about the ward was given prior to the admissions, usually with pictures, so the person can actually see how the ward looks like. There's maybe a description of where each room is or what's happening in each part of the ward. Ideally, maybe they had few orientation visits before admission. So I think sometimes it's really hard. We are busy, you know, our lives as professionals are hard. So sometimes it's hard to imagine that we take so much time and that we really are slow with our decisions, but it really pays off. It really is so important. And that the family members stayed for the admission and maybe helped the person settled in. The person was, well, it's even hard that we say allowed to leave. The person was encouraged actually to listen to their body, to self-regulate. So whenever the group sessions were too overwhelming, they were encouraged actually to leave and to engage in things that were calming and regulating for them. And then again, all this communication thing that Emily just explained, that like we have to be so creative in terms of the individual therapy or our dietetic interventions as well. A lot of the things is to kind of figure out how the person communicates best, what is the best way for them to not feel overwhelmed, for the space to be actually therapeutic and helpful, and also for us to support them in that. So in this case, there were a lot of visual help kind of delivered to the person or created in the therapy sessions, and also the dietitian and the therapist provided a written summary of the session so that the person could reflect on that and they didn't feel so overwhelmed that they didn't remember what was happening. And that again resulted in a very successful treatment. It gave a very successful outcome, both for recovery from the eating disorder, but also in terms of the person learning about their needs, embracing their autism, actually learning what they need to just thrive as a person. That it wasn't just focus on the eating disorder, it also helped the person to just, as therapy should, you know, understand themselves better and function better. And then I also want to focus on the particular food adaptations, because this is like a, you know, like a subset of the accommodations that we need to provide, because eating would be potentially the most distressing time for the person in eating disorder recovery. So we really need to look at that. So definitely more familiarity and predictability than we would give to maybe other clients who are not neuro diverse. So like for many of our clients who have autism, if the food isn't predictable and maybe we don't bring the things that they already are able to consume, it will be too overwhelming and the treatment might not be successful. Of course, we always want to work towards a little bit more flexibility. Again, we can't look at this population with this kind of neurotypical lens, but of course, in eating disorder recovery, we also want to work a little bit on flexibility, but starting with the food range that is familiar and that they can rely on some predictability or similar things being given to them every day is very important. In general, I think we would expect that the person will have a smaller range of foods than a neurotypical person. But again, we can work on expanding that at least to the point that they can eat enough to sustain their bodies and to be healthy. Of course, a very important part of it is the sensory difficulties around the meal times and also related to the food itself. So this is the example here is of a person who maybe is overwhelmed by the food, in terms of the colors, the flavors, the smell and the texture. But of course, there could be the opposite of that as well, that the person might be underwhelmed. So they might actually require very intense smells, very intense flavors and things like that. It all depends on the person. I think it's really important to provide those very basic things like noise canceling headphones if it's required, or even to give the person space. So some people might need to use distractions, or might even need some space for the stimming or the behaviors that they do to self-regulate. So just being mindful of that. we need to have predictable routines. And again, enough notice when changes occur. It's so important because this is such a small adaptation, but it makes a huge difference, because if the person is given enough time, they usually are able to come around. It's just the aspect of surprise, or the aspect of not being in control of it, that's really difficult. And another important thing, that some people, again, not everyone, but some people will have quite low muscle tone. So we have to also be aware of that and provide them either with the foods that take less manipulation or chewing, or even provide utensils that will be easier for them to use, like sometimes those kind of spoons that we use for very little kids that are just easier to manipulate. So just some adaptations to think about. So Pookie Knightsmith is someone that I would recommend, if you don't know her yet, to maybe check her out and listen to her YouTube channel. So this is just the 5 things that she highlighted about the autism and anorexia interplay. And we had a few questions about that in the chat, especially about this interplay of are we seeing autism here, or are we seeing anorexia? So she shared, one of the things she said is that when she was unwell, she sometimes did use, or the eating disorder actually used anorexia, used autism as an excuse to not get certain foods, or to, in the guise of needing adaptations, maybe just get a bit more space for the eating disorder. And that is always the danger. We just have to be really aware of that, and we have to really work with the person. But again, it's even interesting that when we started this conversation, this was the first concern that people had, because I think we're so quick at, because of the traditional view of the treatment of eating disorders. I think in the traditional view, the less accommodations, the better, and the not colluding with the eating disorder is so important. But I think it's so much more complex with this population. Again, it's always a risk, but we have to often take it because we don't have a choice. But it is important that we have those conversations. Also, I think another way that we deal with that in our team is that we have a peer support worker. So we have someone that helps us as a team of professionals to be mindful either that we are going a bit too are we in danger of over accommodating and maybe accommodating eating disorder, or sometimes this person warns us that we are not aware of the accommodations that are needed. So this is like an extra layer of protection for us to feel that we are doing a really good job, to have someone with lived experience on the team. Other things that Pookie mentioned is that she used a different language. She said anorexia is the bully to be beaten, and autism is the French to live with. I would say that anorexia is an adaptation. It was a necessary adaptation that the person needed to make to survive often, or to cope. But yeah, we can always learn to do better. We can always, actually, this is the thing that we work on. And autism is for life. So I think, and again, there was a comment made in the chat before that so often the treatment of eating disorders only focuses on the eating disorders. And it is so important that we also, when we have people who are presenting with both, help them with autism, help them with embracing learning who they are, because that is actually helpful in the recovery. The relapse is much less likely if the person is feeling more full or has more ways to cope. Also, what Deirdre earlier mentioned, and I think Emily mentioned that as well, the language matters, that we would not want to identify and use the language that identifies the person with eating disorder. So we'd not say that someone is anorexic, but sometimes people actually like to be called autistic, or some people might prefer to be called a person with autism. So this depends. We have to really check that with the person that we're working with. And the last one is really important as well, that we can actually use the autistic traits to help the person move forward in recovery. The traits often can be quite neutral, like maybe perfectionism, or focus on detail, or even being quite stubborn, or, all those traits, they can be corrupted by the eating disorder. And then we are in trouble, because those are very powerful tools in the hands of eating disorder. But we can also teach the person or help them to use all those traits in the recovery, to move the power of those traits, because there's actually a lot of power in those traits to be helpful for recovery. And this is probably our biggest job.
And then in terms of supports for families, we already said that the care burden is greater. And equally and importantly, though, there is evidence to suggest that improving the overall well-being and stress levels of caregivers also has a positive impact on loved ones who are autistic and struggling with an eating disorder. So clearly that's very good news. So if we can support the caregivers, they can in turn more effectively support their loved ones. And the support that caregivers want and need is similar for both people who are autistic and who are also struggling with eating disorders. So caregivers want social support from caregivers going through similar struggles, for example, support groups, and not just for parents of children and adolescents, but parents of adult children too, which is a lot of the work that Zuzanna and I do. The parents need skills to manage their stress, so emotion coaching, emotional regulation, and important that they understand, learn more about autism, understand eating disorders better. They need information tailored for their loved ones. What works for neurotypical people mightn't work for their loved one. And very interestingly, we are learning that when things are tailored for neurodivergent people, it benefits neurotypical people too. So it appears to be a kind of a bit of a win-win. Helping caregivers to reduce the blame for themselves, so stop blaming themselves, stop blaming their loved one. If they can improve or increase their own self-compassion, it helps to reduce self-blame. And the level of self-compassion will also predict parents' well-being, even over the level of the loved one's symptoms. So self-compassion is so important, and it's a skill that we need to spend time and develop. And with eating disorders, an increased level of self-compassion leads to lower levels of expressed emotion, such as anxiety, frustration, fear, and anger. And siblings are a very important part of this conversation as well, because as with all eating disorders, this can have an impact on siblings too. They can feel ignored, where all the parental attention is on the autistic individual. So it's very important that there's open conversation, that how the autism is impacting their person is discussed in an open manner, giving information to the siblings. So if they have a good understanding and they can build on positive sibling relationships, it can be really beneficial for everybody. So maintaining the positive regard of the individual and low criticism too. Explaining what's going on, explaining about any supports that the autistic person is getting. So working with the sibling to increase their coping skills is really, really important. And in terms of communication strategies, so some things just kind of bear in mind, trying to be more direct, more to the point, not using sarcasm, not using metaphors, not relying on body language or facial expressions. So saying, I understand what you're saying, not nodding your head. So just kind of adjusting how we communicate. Explain what you are feeling and why, checking in for understanding all of the time, not overloading somebody by the amount of content, if you like, that you're sharing in a conversation. Might be recognizing that it might be easier for the autistic person not to make eye contact. So it gives them time to kind of process what's being said. Being factual, being consistent, providing explanations. For example, if there are snacks required or whatever in an eating disorder context, as we've said already, as Emily said earlier on, asking what will be helpful for the person. And also I think important too, as caregivers, that we keep a note of what we observe, what challenges are facing our loved one. Because often, you know, if they're in treatment and they're going to see clinicians once a week, a lot happens in between times, and it can be really hard for the autistic person, and indeed us as caregivers, to remember what has happened. So you're remembering as caregivers, you're with them more than your treatment team, and your person might forget some of what they struggle with, as I've said.
So I think it's important to note that we live in a neurotypical world. So someone who is neurodiverse, it's in a minority. So they might often have this consistent kind of experience from childhood on, that the expectations that were put on them were not matching their abilities and their needs. And there might be this already kind of learned set of beliefs that come from that we know very well from research, that being in a minority or being in some way stigmatized or being not seen fully for who we are costs us. So I think as professionals, we need to take all this into consideration, and we really, really need to be careful that the treatment setting doesn't remind people or doesn't maybe trigger similar feelings in them, because that experience might already be in them, and they might already have some level of trauma even from that. And when we add eating disorder on top of that, it gets even more complicated, because again, as I said, the traditional approach to recovery is to not give accommodations, actually to nearly say with most of the things that, oh, it's just your eating disorder. So this is more complex for this population, and we definitely need to consider the accommodations there. Hopefully it's clear from this presentation that there are a matter of actually this person being harmed or being well taken care of by us. And we also have to, again, examine our neurotypical bias when it comes to different eating disorder or eating behaviors in general, that some of the behaviors in a neurotypical population, neurodiverse population might actually be right and adaptive and okay for them. We might just have a view that they disorder because they just don't fit into what we've seen in the world or what we consider typical. So this is something that we need to take into consideration as professionals, because this is our responsibility, not the person who comes to us. And also we do need to do better, because we know from experiences like Emily and also research that at the moment people are not accommodated enough, and many people are more harmed than supported in treatment from an eating disorder.
So I guess from kind of what you've heard today in this hour that goes by very quickly, I think a really big thing is taking today what you have learned about the environment, about the engagement, adapting therapies creatively. And I think it's about, for me personally, from lived experience, it's about that use of empathy and walking alongside that person in their world, because, I'm doing my counselling training, I'm learning all about their individual's world. And actually, I think by doing that can be sometimes the most biggest thing for somebody with autism and an eating disorder. From my lived experience, having a professional just sit with me, walk alongside me and be on that journey has been the most empowering experience that I've been through. And it's, the continued professional development, in my lived experience role, I'm constantly training professionals in autism and eating disorders of, what's working and what's not. It's reviewing your practice, it's the reflections. And it's really important that, the continuing professional development. And it's coming to events like this because you learn from lived experience, you learn from clinicians, and it's just, being your authentic self as a professional and being who you are with that individual and working with their needs as much as you possibly can. And that for me, empowered me to be the best that I could be. So for those of you, in case you don't know where this quote comes from, The Greatest Showman was my lifeline in lockdown, still is now to this day. And one of the songs called This Is Me, so it goes, I am brave, I am bruised, I am who I'm meant to be, and this is me. And we use a saying in our service and in some coaching work that I do with a charity, that by being different, we succeed together and we become the best that we can be in our own amazing ways.
And we are at the end because we are conscious we've run over by a few minutes. The slides will be shared afterwards along with the recording, and we have put some useful resources. So we've had lots of questions about the peace pathway, so the links are here. We omitted to include, but should, the new Maudsley carer workshops that Jenny Langley runs. I know Jenny is here. And they're also run in Ireland with Bodywise, who are on our slide. And Jenny and Bodywise also run a podcast series, which might be very helpful. So we can include those when we share the slides. And then just in terms of kind of some of myself and Zuzanna's own work, We run online events for professionals as well as families and those affected by eating disorders, as I've said already. Tonight, as it happens, we have our bi-monthly peer group for eating disorder professionals in the UK and Ireland. It's free to attend. Zuzanna is delivering a webinar next week for the International Association of Eating Disorder Professionals on treating long-standing eating disorders. So both of those can be accessed via the QR code. We run an online monthly support group for parents, which is on Wednesday. And we also run a recovery compass, so teaching caregivers the skills, tools and strategies that they need to support eating disorder recovery. We've lots of free resources, webinars and blogs on our website too.
So if you do want to engage with me further, the best way to contact me is on my email, which is emily@cwgsy.net. So it's a Guernsey email, being based in the Channel Islands. I'm also available on LinkedIn and also on Twitter. So I'm happy. I know there's been quite a lot of lived experience questions that I've done my best to answer, and a few clinician ones. But if you need some further sort of input on that or further information, and I can also put you into contact with Peace Pathway teams that I work with and other national teams that I'm a part of with Maudsley and Kings and Freed. So if you do need that information, we can touch base and make those connections and work together to hopefully help you in this area of autism and eating disorders.
And similarly, there are contact details, so please do keep in touch. And you can sign up for our newsletter to stay informed in what we have going on. So apologies for overrunning slightly. And we've done our best to answer the questions as we go along in the chat. Over to you, Aish.
Wonderful. Thank you very much all. If there's nothing else further, then do please feel free to drop out of the session. Otherwise, I'd just like to thank the three of you, Emily, Deirdre and Zuzanna, for obviously joining us for today. All of those talks were so insightful and so informative. They were very, very good. So yeah, just a big thank you to you all, and I will be in touch with the three of you via email.
Great. Thank you very much.